I am very proud to be able to introduce to you the keynote speaker, although the Dean did a fair amount of that when she was talking about Donna earlier, so I will try not to repeat any of that. Dr. Donna Havens started her nursing career in 1970. Her baccalaureate degree is from Cedar Crest in Allentown. Her MSN, as you heard from the Dean, is from Villanova. Her PhD is from the University of Maryland, and she also completed a postdoctoral research fellowship at the University of Pennsylvania. She has held several faculty positions in the past, including an endowed professorship at Penn State. She has been at the University of North Carolina since 2003, where she is currently professor and division chair, director. In the past, she has also held positions related to research, outcomes, administration, and informatics at Geisinger Health System, as well as Duke University. Dr. Havens has been the recipient of numerous awards, including the 2009 Nurse Researcher Award from the American Organization of Nurse Executives and the 2000 Villanova University Alumni Distinguished Contributions to Nursing Medallion. She has been a fellow in the Academy of Nursing, and I believe it's since 2004. She has published numerous articles related to health services, the Magnet Hospital Program, and nursing care quality, which is what brings her to us today. She has been a sought-after speaker on a number of topics related to her research and her expertise in quality care issues in nursing. She has been involved in instrument development, specifically of the Decisional Involvement scale, which has been used around the world, as well as in a slew of hospitals in the United States. She has been principal investigator or co-investigator on a number of funded projects from agencies such as the National Institute of Nursing Research at NIH, the Robert Wood Johnson Foundation, and her current $1.3 million grant from HRSA, the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services. Donna Havens is a member of a number of professional organizations in and outside of nursing, which I think is particularly important. You know, that it's not just nursing, but it's nursing in other disciplines in order to have a broader impact, including the Eastern Nursing Research Society, or ENRS. It was actually through ENRS that I first met Donna when, as president-elect of that organization, I watched her put together and manage and pull off, without a snag, what I still consider one of ENRS's most outstanding conferences. It was unbelievable, Donna. There is much more I could say about Donna, but I will stop here so that we have ample opportunity to hear her presentation today on designing nursing systems to promote desired outcomes. Please welcome Donna Sullivan Havens back to Villanova's College of Nursing.
Okay, after all of that, you're going to embarrass me now. Let's see if I can make this. Okay. Sharon? Let's try it this way. Okay. Thank you very much. And Louise, you welcomed me to come home. You welcomed me home, and I feel that I am home. Thank you very much. I was thinking earlier about all of the great dinners I had between classes out in the other rooms, and the great colleagues that I made, and friendships, and some of those first ideas that sparked a lot of my career to date. So thank you. I want to thank the College of Nursing, Dean Fitzpatrick, the Center for Nursing Research, Center for Continuing Education in Healthcare, and Sigma Theta Tau Alpha Nu for inviting me tonight, to the faculty, the students, to the members of the community, and to those who have walked before me. I need to keep in mind that what I do really is built by standing on the shoulders of a lot of others who walked before me. I'm very fortunate to be able to use their work to build on, to continue my work. And to those who've shared their stories and worked with me as partners and colleagues. You're going to hear a little bit of different research tonight, but it's going to take all of you who are leaders, managers, students, nurses, faculty, administrators, everyone, It's going to take us to continue this work together as partners. So, let me begin by saying that research, a great body of research, has shown us that there are certain organizational features in the organization of nursing that are associated with positive outcomes, not just for patients, but also for nurses. And some of those features, research shows us, involves nurse involvement in decision-making about patient care and nursing work, about communication and collaboration amongst all providers, but also between nurses and nurses. In other words, what's good for nurses also, research shows us, is good for patients. And I have to tell you, a third thing we sort of fell into when we started working on communication collaboration was the needs of the hospitals we've been working with to deal with the whole notion of bullying in the workplace and civility at work. So that has crept in there and helped us to see that you can't even begin to work on communication and collaboration unless you deal with some of these other issues, which apparently are really growing in the workplace today. So this line of work is important because these features I've told you about, decisional involvement, communication, collaboration, these features have been linked through research studies to nurse retention. And we know that shortages of nurses, some feel it's easing now because of the economic climate, but we're warned that it's going to come back and hit us big time shortly when the economic environment levels out. Shortages of nurses impact access to patient care, quality, and safety. Nurses are the glue that hold the whole healthcare system together. We're safety sentinels. We're the first group to notify someone when something is wrong. We send out that call for help or we do something to solve that problem. We rescue patients. And improvement in the organization of nursing, organization of nurses' work, has implications for quality of care. So what I'm really talking about today is evidence-based leadership and management. We talk about evidence-based practice, and I'm asking you to extend that just a little more. Why shouldn't our whole way of organizing, leading, and managing also be based on evidence? Because the evidence is there. So my plan for the next 40 minutes, 35, is to tell you about a research program, my research program, to shape systems to promote desired outcomes. And it's really implementing enhanced nursing practice environments in rural hospitals, which is also a little different. So I'd like you all to just sort of sit back, relax, and let me tell you a story. Okay, a little different way to present research too. But this is about an ongoing, evolving story. And there's a table of contents in this book, just like any good book you pick up. And this really tells you what my research program has been about throughout my career, okay? How it came to be, professional practice models, early magnet research, nursing executive turnover. Those two chapters highlighted in red are what I plan to share with you tonight. Partnering with practice to improve retention and quality, and that really involves dissemination, translation, and implementation work, and share a little bit about what we're learning. So we're going to start with Chapter 7, and that is partnering with practice to utilize knowledge. Knowledge about management and leadership to improve care and improve nursing work. So as every good story begins with once upon a time, we had 20 plus years of research that showed us that professional nursing practice environments were associated with positive outcomes for nurses and patients. And research linked the features I'm going to share with you tonight with recruitment, retention, and quality. Researchers throughout these 20 plus years of work always recommended that we needed to implement these features, but no one ever really talked about how you do this. And even more importantly, how do you sustain it? How do you make it stick? So this presentation is about an emerging story, about a service research partnership, okay, practice research, to build capacity to implement these features in community hospitals in rural, underserved areas in Pennsylvania. Why rural nursing practice? It's often a forgotten element of practice and patient care. Yet, 41% of the U.S. non-federal short-term general and specialty hospitals are in rural communities, 41%. There's an RN shortage in rural areas that is far greater than what we find in urban areas, and it presents unique challenges to recruiting and retaining nurses. There's physical isolation in some of these communities that isn't really drawing and attracting new people to live there. It's a static community of personnel and patients. The people will tell you that their fathers, their grandfathers, their mothers, their children all worked in these hospitals, that their patients are their neighbors, their ministers, their priests, their children's school teachers, and the coaches of their children, their neighbors, so they know everybody. There's very little change. And students are rarely exposed to these settings through their clinical practice. So therefore, they haven't had a taste of it, and it's probably unlikely, unless they grew up in these settings, that many will actually go back to them. The nurse execs in these hospitals in rural communities will tell you that they need their practice environments to be a cut above, yet they don't really have the money to implement huge programs like many of the urban environments. They need to be able to keep their nurses. They want to recruit from schools in urban areas. And the Rural Healthcare Association is very concerned about nursing practice in rural hospitals and has encouraged them to think about using Magnet, the ANCC Magnet Recognition Program as a guide, or the new Pathway to Excellence program as a guide to shape rural nursing practice. So I've been involved, it's been 7 years now, in 2 studies, one sort of built and carried on from the other, to enhance nursing work environment, to retain nurses and improve the quality of care. And these are our 3 objectives: decisional involvement, communication, collaboration, and civility and respect at work. And these logos are really the 2 logos for our 2 studies. We first began in 2004, and we began our second study in 2008. And I'll tell you how this is all sort of molded and evolved and blossomed together. The funding is from HRSA, from the Bureau of Health Professions, and when you have funding from major organizations, they demand that you announce when you're sharing any information that what I'm sharing is my interpretation, my perceptions. This is not HRSA's findings or perceptions. Now, I want to stress very importantly, first of all, we started calling the hospitals we were working with project hospitals. And it didn't take long before we realized that was really not a good word to use. These were our partner hospitals. These were our partners, and we had to show right from the get-go that we were really partners, not researchers coming in to use them for data, which is a big concern. And partnership, we're really doing action research, community action research, but we're doing it in hospitals. Those are our communities. And partnerships with the community of interest bring together the expertise of the researchers with the expertise of those in the organizations. And it really helps to lay a foundation for sustainability. Here are our partner hospitals. Now I say 11. We've had 2 groups, 2 studies. The first group was Hospital 1 through 6. And our second group, which started in 2008, starts with number 7 through 11. You can see these are not large hospitals. And in fact, number 7, is a community access hospital with 25 acute care beds. The rest are skilled beds. And these hospitals were picked by interviewing, by working with the State Department of Health to use the state licensure data. Nurses submit data when they renew their license about satisfaction, intent to retire, intent to turn over. So we looked for those communities also in underserved areas that had nurses that were somewhat older, expressed an interest in leaving, not the most satisfied, et cetera. And then we conducted extensive interviews with the hospitals to get their buy-in. You can't go in and do this to somebody. They have to be your partner and want to work with you. And we needed the board's support, and we needed the CEO's support also, because we were expecting money from them to help fund part of this study. Why Pennsylvania? Because 28 of the counties are listed by the Bureau of Health Professions as nurse shortage areas. Also, the Department of Health data was very strong data. It is strong data that still exists. Linda Aiken has done a lot of work in Pennsylvania, so I was able to use, she actually graciously granted us some of her data for our project hospitals to submit as our preliminary data. And the relationships. Several of you talked about the importance of the relationships, the school going in. I had built relationships here, and this study would have never gotten off the ground, either one, without being accepted as honest, reliable, strong person that people knew you had a history and a reputation. And that's what really helped launch these studies. So, conceptualization. I have to say that there were prior attempts to implement elements of professional practice models in hospitals in the past, dating back to the 80s. So we tried to build on or strengthen some of those areas, such as most of them were single site studies. We had one study with 6 and another with 5. And now we have all the data from 11 hospitals that we are able to go forward with. Most in the past had small samples. We had larger samples. Most did an intervention and then measured the results in 6 to 12 months, when the literature will tell you it takes up to 5 years to see change. So we tried to deal with some of those, and also, most importantly, where we're still trying to go, and we will in the next few years, most studies in the past never dealt with the dose of the intervention. What was done, how much was done, but even more importantly, how did hospitals take it up? Did they implement what you were sharing with them as you intended? Did they adapt it? Did they change it? Did they do part of it, or did they only do it on Thursdays? So we're trying to capture all of that. And the intervention, we actually implemented a quality improvement collaborative. Now, I don't know if you've heard about that. Institute of Medicine proposes those. Institute for Healthcare Improvement have quality improvement collaboratives where they bring teams and groups together from different organizations, and most often they work on clinical care, bundles for ventilation in ICUs, ways to deal with sepsis. We're doing a quality improvement collaborative to deal with the organization of nursing practice in hospitals, okay? Same thing, bringing teams together to work together on these 3 project objectives. And we based our intervention on theories. Capacity development was one, diffusion of innovations, and the theory of positive organizational change. Okay, and I'll tell you a little more about those. Capacity development came from the literature in third world countries. How do you help governments and populations build the capacity to do what they need to do? We borrowed that literature, and it seemed right on target for us. Capacity development's about putting in place structures, processes, roles, and skills. And it's facilitated through coaching, training, technical assistance, networking, and tools. And in terms of increasing the rate of implementation of innovation, Rogers, okay, gives us some clues that if people can see how something's going to look when they do it, they're more likely to do it. So they were able to try on from watching their other team members and other partners. They're able to see how complex things are. If it looks simple and somebody else was able to do this, then you're more likely to want to do it. And so they're able to speed up the rate of implementation and acceptance of this innovation. So we applied those principles. And then positive organizational change. It's a new discipline. There are actually master's theses and dissertations coming out of this field where looks at positive things that are happening instead of always looking at what's wrong. And they measure things like resilience, joy, satisfaction instead of dissatisfaction. If you're really interested, go to the University of Michigan Business School website. Their whole curriculum is designed around positive organizational scholarship. That's the name of this field. So, what were our capacity development strategies? What are the components we use in this collaborative? How the intervention works, in other words. I'm going to go through each one of these, but it's appreciative inquiry, which comes out of that positive organizational development, data collection, meetings, Magnet Hospital Mentors, website, and networking. And let me just explain this positive organizational science piece that we're using. We're using appreciative inquiry, and there have been something like, I think, 52 articles written in the past 10 years relative to healthcare on using this particular tool. So the traditional approach to change is looking for the problems, identifying who did it, what's wrong, what are the barriers, who do we blame, and how do we fix the problems, okay? It's the root cause of problems. We do a root cause analysis. Whereas appreciative inquiry is a more positive approach to change. What is working or has worked in the past? So we say to our folks, we have them go interview maybe physicians and identify when they communicated or collaborated that produced an excellent outcome. What was the situation? Who did what? How did it work? And more importantly, how could they make it happen again? Okay? That's the appreciative approach. That's the root cause of success, and that's a story that often we don't find out about. Data collection and feedback. We collect data from the nurses in all of our hospitals every year for 5 years. Talked about IRB approvals before. Yes, we got the university IRB approval and then had to get IRB approval from all of our partner hospitals, which was an interesting experience. We knew it was going to take time, took much longer than we ever dreamed because many of these hospitals didn't even have an IRB board, institutional review board, but they had committees of physicians, all of whom wanted to review everything that we were going to do. And there were times when we just kept getting back questions like, okay, but where are the drugs? What about the drug study that's part of this? So it took a lot of communication. A big understanding needed to be developed on our part about how you do this. But we did get approval. They finally threw their hands up and realized there was no money from any drug company and there wasn't going to be a drug study. So we did this. We also learned very early in this stage to accept our partners' wishes. Some of our nurse execs didn't like the survey questions we were going to ask. And that was sort of the first thing. In fact, they had gotten together and met before we even had our meeting to go over the survey and said, no, we don't like some of these questions. We don't want you to ask them. And that was a huge test for our team's part. Because if we had stood our ground and research colleagues were saying, but you're the researchers. You need to tell them what you're going to measure and what you're going to do. And we would not have been in year 11 today had we held that ground. And this is part of community action research. So we backed up and we said we understand, okay, and we worked out for those problematic questions some other things to deal with. We also used multiple measures that are used in other Pennsylvania studies and national studies. And these were the variables we measure. Notice we do measure emotional exhaustion because that's what is out there in most of the studies, but we also measure engagement. And part of this data collection every year is we present a report back to the hospitals every year with their data, shows them across their units, across their hospital, and how they compare to the other partner hospitals on average. And I want to call to your attention, it says red hospital, okay? No hospital is ever called by name in these reports or in any presentation. They were randomly assigned colors. We didn't want to go with numbers. We didn't want to go with letters of the alphabet because there's a hierarchy here. We learned very early it was about being fair, everybody being on level ground, so they all have a color. They were told they could share the color, their color, with others if they wished. The first group never did share their color with others, but everyone in their group knew their color. They'd be whispering, "What's our color?" Well, we'd get together and they'd write it down and fold it up so they knew their colors. And so the whole thing about the data collection is we collect it, we give it back to them in terms of a report. Showing comparisons was really important for them. And they make sense of it and help us translate that data into knowledge. Then we meet with them and help them decide what practice and administrative changes they want to make based on their data. We have face-to-face meetings They're 1.5 days, 3 to 4 times a day, 3 to 4 times a year for 3 years. That's all the government will pay for. 3 years of activity in these projects. The last 2 years, they're supposed to show sustainability and just provide data to you to evaluate it. We thought there'd be 4 to 6 people coming from each hospital. The past 3 years, most hospitals have been bringing 8 to 17. Now, these are small rural hospitals. One in one of the most poor counties in the state. They're paying their own way to bring their team members. So they're paying transportation, they're paying hotel rooms, but they feel this is helping them jumpstart the organization of nursing. We also thought there would be the same few, you know, the organizational literature will tell you you develop a cadre of individuals. Well, they're deciding to reward nurses. So coming to the collaboratives based on reward. Or it might be based on a nurse who did a particular thing last year or wrote a particular essay. Or they might want to, others are doing it to spread the word to more people, so they're bringing different teams every time. This is part of what we need to be evaluating and what we're keeping track of. We thought it would be multidisciplinary. Rarely does anyone outside of nursing come. We've begged, we've invited, rarely. And there's pressure to perform. These are every 3 months, and they're very worried when month 2 has approached because they have to share with everybody else what they've done and how they've worked on the objectives and what things they're putting in place. It's a lot of pressure to perform. This is our collaborative meeting attendance. This is with the first group, the first study I told you about. You see collaborative 1, we had a little less than 45 people. That's about what we had budgeted for and planned for with the first grant. You can see at the end of 3 years at collaborative 7 how many people were coming. This involves partner hospitals and magnet mentors. We found magnet mentors were increasing the numbers that they're bringing. In this second study, it's very usual for them to bring maybe 4 people to the collaboratives. They claim they're learning as much as the partner hospitals. The magnet mentors, we built their roles based on focus groups we did with magnet hospitals about how they help others, what they're asked for. They work with the partner hospitals. They take road trips. The partners have gone to visit mentors. Mentors have gone to visit the partners. They email, they call, and they review materials. They really just provide support. For instance, how did the magnets improve communication collaboration? We're not making magnet hospitals in any way here, but they've implemented some of these same things. Here's the list of the magnet mentors, many in this area. Anyone here today from any of these hospitals? Okay, thank you. Thank you very much. And these groups, some of these were part of the first study and they're part of the second study. So for this group, that's 7 years. And when we needed to know if they wanted to be part of the second group, within 24 hours, they all sent a letter saying yes, they wanted to be part of the second group. We have a website that provides toolkits, references, resources, and folks said they wanted to be connected to each other. So one of our small hospitals has over 200 nurses that have signed up to be on our website. So this website is only available to the partners, nobody else. We had to build that trust so that if they send policies, procedures, we have magnet hospitals that have put their entire set of bylaws for nursing on our website and told the other partners, feel free to adapt, modify, copy, don't start over, use whatever you can. So we keep this very private, it's password protected, and everyone has agreed to keep this their project. And they can communicate with each other now simply by clicking a little box next to the person's name and email address. And you find now the OR nurses are starting to communicate with the OR nurses in another institution, or the ED nurses are communicating with the ED nurses in another organization. So what are we learning? A small look at a big picture. I have to warn you that when I first started down this trek years and years ago, I was warned that this is very messy and was not going to be the type of research that would be easily explained or easily embraced by people. And I was warned by those who had tried this, those in the 80s and 90s, that I really needed to sit down and think carefully about this. But if no one does this, how are we ever going to make these changes, these evidence-based changes in practice? So I ventured down the road, and I have to say, it's been the ride of my life. So they're building processes, structures. Remember I said capacity development, roles and skills. What are they doing? For decisional involvement, here's some of the things they're doing. All of our newest group have implemented now in 3 years unit-based councils. Some have moved to hospital-based councils, using the bylaws and all that the magnets and one another have provided to each other. New manager roles. That was very difficult. Nurse managers are having a very difficult time giving up their traditional role. It's a little threatening when you've managed one particular way. So we're helping them to see this is elevating the role of the nurse manager. It becomes more of a coach and mentor while the staff take on responsibility for other things. How do we give RNs time off the unit when they need to be there to give patient care? Some of the things that have come up. And we've also got 2 hospitals that have collective bargaining for the nurses who are in this second group. And they're dealing with how do you implement shared governance in a collective bargaining environment. And some of our mentors are helping them because they have collective bargaining for the staff. So much is being learned by all. Structures and processes for enhanced communication. Some have developed what they're calling respectful communication teams, multidisciplinary, handoff sheets when patients go to different units. Most of this, all of this is new for our partner hospitals. They weren't doing these things. SBAR they're using pretty regularly now, having huddles. Schwartz rounds, they're very interested in Schwartz rounds. Google Schwartz rounds if you haven't seen it, where you get multidisciplinary folks together in a room once a month to talk about cases or a particular patient care issue that was emotionally draining to everybody. And zero tolerance policies. They're once again borrowing one another's and rewriting them. Civility and respect, I said, emerged as something huge, huge. They call it death by 1,000 paper cuts. And most people who've experienced incivility at work or bullying will say that's pretty much right on target. No bullying campaigns have been started by a few. Several have realized, just like SBAR is standardized language to talk about patient care, they've developed a standardized language for civility and bullying so that they have done some education. And some are simply using the word ouch. If somebody says something to you, everyone knows what ouch means. I heard that and that hurt my feelings, or I heard that and that was uncivil. Some are talking about flipping. They have nurses use name badges. So a couple of the mentor hospitals and now the partners, on the back of the name badge, when you flip it up, it will have a smiley face or something that says ouch. And somebody does something or says something or they're gossiping, they just flip their badge. Once again, standardized behavior, standardized language. And we have a lot of brown bag conference calls where those who can't come to the face-to-face meetings are able to do conference calls that we sponsor, and it's often we have over 100 nurses on the conference calls from both the magnets and the partner hospitals. What are we learning? It's a work in progress. We're using the decisional involvement scale, obviously, to measure staff RN involvement, and it looks at 6 different areas. Staffing and scheduling, anytime we've used this instrument, is the one nurses want to be most involved and seem to start moving in that direction fastest, but they quickly then move into quality issues and quality councils. This shows 2004, 2009, our first group. This is what we report to them. I show this to you. I don't have p-values, significance. I have stars to show significance. We try to give them a picture that they can see and understand quickly. The red bar would be shared governance. If you look at the bottom, 1 would mean all decisions were made by management, 5 would mean all decisions are made by staff, and 3 is equally shared. The dark blue was where the nurses, 1,100 nurses said they were in 2004, and the light blue is where a few less than that, I think, in 2000, no, we looked at all these together, 1,100 in this analysis. The light blue is where they said they were in 2009. 4 showed significant increases. Three showed significant increases. One showed a statistically significant decrease, the Blue Hospital. That hospital had a lot of things going on, a lot of change in leadership. A consultant was hired who recommended downsizing the RN nurse workforce. All of these things, so messy. You're trying to do something, yet you have to account for everything else that's going on in the environment. What could I say to the board of directors? No, you can't do that. I'm doing a research study. Obviously not. But we're accounting for all of those things and when they happened. I also want to point this out to you. I showed you by hospital decisional involvement. This is when we look at it across nursing units. It shows how much information is lost when you roll, for instance, all the units in one hospital up into one little statistic. Look at the variation across nursing units. With the blue, this decisional involvement scale asks nurses to say who they think is actually making decisions and who they think should actually make the decisions, okay? So it's sort of where they think they are today and where they think they want to be. So the gold is where they want to be. The blue is where they think they are. Look at Unit B, right on top of where they want to be. The other interesting one is look at Unit F. They actually want to be less involved than they thought they were. So this is why it's important to look deeper. And this is the kind of work we do with the hospitals. We also use this kind of work to talk about positive deviance. You heard about positive deviance? Positive deviance are those folks that are operating in the same environment, the same culture, the same organization, yet some are able to do things very differently from others. And the key is to find out what they're doing, how they're doing it, how they make it happen. What's that context? So that others can figure out how to do it. Relational coordination, I talked with Mike earlier, yes. This is something from Jody Hoffer-Gattel. This is how we're measuring communication collaboration. She has done a great deal of research. I encourage you to look in the literature. But she sees relational coordination as consisting of 4 elements of communication: timely, frequent, accurate, and problem solving, and 3 elements of relationships built on shared knowledge. Shared knowledge means that all of the healthcare providers understand one another's role. And they understand how their role, for instance, nurses, fits in with dietitians, physicians, therapists, and mutual respect. You can see this is our newest group we're using relational coordination. There's been some change since 2008, some more than others. And we also found in relational coordination, not a surprise, highest among nurses on the same nursing units, weakest every time we measure it between nurses and therapists, and physicians out of the 5 providers we look at rank number 3, okay? And highest amongst perioperative nurses when you're looking at nurses communicating with nurses on different units, which you would hope to see. That's good. Perioperative nurses are dealing with transfers and patients coming from different areas. This we didn't expect to see. Weakest when you looked at nurse-to-nurse communication across different units, weakest amongst ED nurses and other units. And if you go look in the literature, you'll read about the state of chaos in EDs in America today and the fact that there is no coordination and how difficult it is to practice there. And the 2 most important predictors of relational communication for nurses were respect for the work nurses do with their patients by all other providers, and problem solving versus blaming communications, which are things we can try to work on. And they related these as being very, very significantly associated with quality of care. Workplace civility, we're using an index that the VA is using, tried and tested, and now we're able to compare our data to the VA hospitals. And you can see the civility composites from 08 to 010 seem to be improving. When we looked at a similar measure with our first group, we actually found that in years 2 and 3, the scores went lower. They decreased, and then picked up in 4 and 5. When we talked to other people, we learned that this may be one of those concepts where people start out thinking, well, we're pretty civil to everybody. We don't have any problems with that. And then the more you expose them to education and information, people are going, well, I guess I do gossip a bit, and I maybe do hurt people's feelings. So that was something interesting we saw, and be interesting to see if that happens again. We also looked at the quality of the practice environment using a scale, the practice environment scale that's probably the most frequently used. It's used in Pennsylvania, many other places. It comes out of the group at Penn. And we just wanted to put that in there so we'd have another way of comparing. And once again, the picture they can see very quickly and easily showed 2004, 2009, the changes. I called your attention. 4 had significant gains. 1 actually decreased, the Purple Hospital. A lot of things going on there, and if you talk about the dose, who took up what dose, hands down, the Purple Hospital that time didn't take advantage of everything available to them. So that wasn't a surprise. And the green was, we had some magnet data, so we just showed our hospitals in comparison with one magnet hospital in another state. That's what we had at the time. But you can see the red is where they were in 2009, and across many of the components wasn't that different from the magnet hospital. And this I show you because it's one of the components of this instrument that would relate very much to our decisional involvement, nurse perceptions of their participation in hospital affairs. Once again, some nice change in most of them. What we're doing now is on our survey, we asked every nurse to create her own self-generated ID code. So we don't have their names, we don't have their social security numbers, but if you look through, every nurse creates their own ID code. These questions appear on every survey every year, and they can always recreate this because it's not like a password that you've forgotten. And so now we're putting all those self-generated ID codes together for the nurses that we have them for all those years to look at that data over time for the same people. Reflections. Anyone starting to do this again, I would tell you, remember you need time, and these organizations need time to develop. And I can't say enough about the dose and the timing. Things that happened, 3 CNOs turned over in our first group. Remember, they were our major person bringing us in, okay? They gave us entree. 2 CEOs turned over. They wrote the letter saying, we'll pay for all of these things, we're behind you. Site coordinators, every hospital gave us a site coordinator, 0.25% of their time to help with surveys, to be the communicator, to start all of these initiatives. Leader changes. I told you a consultant came in to 1 and eliminated nursing positions. 2 hospitals changed names, multiple other initiatives. I can't tell you how many had IT initiatives going on. Once again, we couldn't say, no, we have to keep this pure. This is a research study. You can't implement the electronic record this year. So you had to just make note of all of those things. We're doing more analysis, and we're going to pay attention to the dose. What we didn't anticipate was the popularity and the expense of these face-to-face meetings. We had to do some very creative juggling of the budget. We found ways to do some things cheaper so we could bring more people to the meeting. We found that this was a full-time communication effort, in particularly for me as the project director. You were dealing with CEOs and CNOs, and they wanted to deal with me. And they would get back to me within 28 to 48 hours, hands down, and I needed to do the same. This was part of our partnership. We were also competing with very sophisticated data reports. The amount of data that hospitals get back now from whatever organizations they belong to, and we were competing with this. Here we had, 4 doctoral students in a 6x10 cubicle doing PowerPoint slides. So we were really trying, and we actually did quite well. What we did in their hospital reports was to give them PowerPoint slides that they were free to use any way they wish. Delete, add to, whatever. But our data presentation wasn't quite as slick. I would probably put in slick data the next time around, but ours allowed us to be a lot more flexible. Political sensitivity, the lack of self-confidence in these little rural hospitals really struck us. We didn't expect that. In fact, the first group took them a good year before they would even reach out to the magnet hospitals. Why? They said they didn't know what to ask them. and they were afraid they would look like country bumpkins. Those are the words they used. So it was about confidence building. Measuring cultural awareness, I told you. This community built, once everyone guaranteed to share alike, and protect this information. Their mottos, they had two. One was rob and deploy for R&D, and the second was steal shamelessly and adapt. And they're all doing that. Even the magnets now are borrowing from each other. So what we have today now, the first group stuck around. They're still helping. They're called peer advisors. They're helping the second group. A 21 hospital network now that's working on raising nursing practice in these hospitals. Appreciative inquiry, as I said, people take things and adapt them and modify them. The developers could never imagine the things that are going on with this and how it's being used. But people are using pieces that are working in their organization, that meet their context, the word Dr. Fitzpatrick used earlier. Good stuff. Nursing-led change is spreading across other departments. This was a grant funded by the federal government as an initiative to help the nursing shortage. So nurses were to be involved, but this spread, we've had radiology departments taking our survey now. One hospital has asked for permission to use the whole survey for all of the departments. We've had dietitian and pharmacy departments come up to see one of our nurse execs and say, what is this that nursing is doing? What's going on in nursing, and how come we're not doing it? So the nurse execs are teaching some of the other departments. We had a radiology department that decided to adopt appreciative inquiry to come up with their strategic plan, their strategy for how they were going to treat patients. Magnets revised some of their programs based on what partners were developing. We had a magnet hospital revise their entire governance system, and another one revised their clinical ladder. The M word is being used more and more often, magnet, even though that wasn't a goal, and the pathway to excellence. And I have to tell you, we are so proud. One of the first hospitals in our first group became the first hospital on the East Coast to win the Pathway to Excellence Award from the American Nurses Credentialing Center. That became their goal around year 3. Our second group, we have 5 hospitals, and 4 are announcing. You know, the magnets always talk about their journey. 4 of the second partner hospital group is saying, we're on our journey to Pathway to Excellence. So we'll see. That wasn't part of the deal, but they want to go to that level. We as a team are trying to move forward, and we've had some grant we're submitting to look at what's working for what hospitals under what circumstances and why. Some case comparisons of what works for who, what dose, etc. Self-organized sustainability. The first group has organized their own phase 2. They hold their own face-to-face learning collaboratives once a year. They're now organizing their 5th. Okay, this is 5 years. And they've invited the second group to come to it in September. Magnet hospitals, the Maryland group, we had a Maryland magnet, and a Pennsylvania group have now organized their own collaboratives to help one another as magnets. And we have 21 hospitals working together. So I leave you with this. One of the greatest needs of our time, so often disregarded, is to capture that which works and replicate it when it suits. That came from the cover of the first magnet hospital study. It was written by Bernice Ferguson. And that's what this is all about. Finding out what works and how can you replicate it to make it better. And I had to shout out the people who were partners from partner hospitals, from mentor hospitals. What hospitals are you from?
I work at Mainline Health.
Mainline Health, yep.
Wasn't part of it, but I-
Anyone else? Lehigh Valley, anyone else? Okay, thank you. Big, big contributors.